Welcome. Today we're going to talk about risk factors and how we perceive risk. This is obviously very important to us as doctors, and we'll get through exactly why it's important to us as we go through the slides. So first of all, we need to understand the concept of risk. We take risks every day. We take risks by crossing the road, we take risks when we turn on an electrical device, we take risks in every aspect of our lives. And we also do this quite unconsciously. Most of the time we don't even recognize the fact that we're taking a risk. We minimize the risks we take in loads of different ways. For example, we might put a seatbelt on when we're driving in the car. We might have an isolating switch that cuts off our electrical devices so that they don't electrocute us. Or we might refuse to take sweets from strangers. All of these things are risks that we recognize, but we may not think about at the time, and that we've taken steps to try and reduce. How big are the risks we take? Now, this is a very interesting question. We often don't know. We recognize that something is a risk, but we often don't know how big a risk it actually is. We've often got a gut feeling about it, and we often think this may be a problem for me, but our gut feelings, as research has shown, are often wrong. This table tries to give us some idea of some common risks that people will recognize, or some common problems that people might recognize, and the chance they happen. So for example, if you wanted to look at what are your chances of dying on the road if you were driving for approximately 50 years, you've got a 1 in 85 chance of that happening. Of dying of any cause in the next year as just a general member of the population, not taking into consideration your age or any other factors, you've probably got about a 1 in 100 chance of dying of any cause in the next year. When we get down to the other end of this table, we can look at some things like death by playing soccer, and for there you'll see death by playing soccer, relatively low risk, 1 in 50,000, so pretty uncommon thing to happen to you. It's higher than your risk of dying by murder though, and death by murder is twice as unlikely to happen to you, 1 in 100,000. So if you ask people what's more likely, are you more likely to die playing soccer or by being murdered, most people would probably think murder, but as the statistics show us here, soccer's much more risky. And then when we get down to some really rare things that we know are really rare because we use them as examples, your chances of getting struck by lightning are about 1 in 10 million. So very unlikely to happen. Slightly less likely to happen than winning the lottery. It's important to recognize that we often overestimate some risks. For example, let's have a look at terrorism versus dying on the road. Your risk of dying from a terrorist-related attack in the UK, if we consider the average rate of death in each year from the year 2000 to 2013, are about 1 in 16 million. So very unlikely, less than your risk of getting struck by lightning, as you'll see from the previous slide. Your risk of dying in a transport-related accident on roads in the UK, 1 in 16,000. So that was for the year 2004. The risk of dying on the road in 2004 for any given person in the country was about 1 in 16,000. When we compare these two risks, we can see that you are 1,000 times more likely to die on the road than you are in a terrorism-related attack. And yet most people would be very concerned about terrorism and not very concerned about dying on the road. And we don't tend to think of getting into a car or crossing the road as a risky event. So what overestimate, and how do we perceive them? Well, we tend to get very excited about extreme sudden events and not so excited about things that happen gradually. For example, we're very worried about the threat of a tsunami or a bomb blowing us up, whereas we're not very worried about much higher risk of damage to human health from things like climate change or obesity, which are what we call kind of slow burn problems that don't cause damage immediately but are likely to cause damage in the next 10-20 years. Stuff we're scared of tends to get overestimated. We're much more afraid of snakes or murderers than we are of cars or medications, even though cars and medications seem to be much more likely to kill us. Things we can't control tend to worry us more. For example, we're often worried about the pesticides other people put on our fruit or our vegetables. And when we see another driver on their telephone driving in the car, we get very, very upset and exercised by that. Compare that to the risk of fatty food, which is much higher than the risk of pesticides, which we can control, or us using the phone while driving, which is another risk we can control. Those sorts of things we tend to underestimate relative to the things we can't control. We also tend to overestimate risk of things that we consider unnatural. So generally, if something comes from nature, we think it's less risky. For example, people get a lot more worried about the risk of a nuclear meltdown and nuclear power problems than the risk of solar radiation, and we're much more likely to die of skin cancer than we are of a nuclear meltdown. So this brings us onto the concept of a risk factor. And this is a term that we use every day as doctors, and that is very important for us to understand. Basically, what is a risk factor? It's something about an individual that makes them at greater risk for a given disease or set of conditions. And some basic examples here: smoking is a great risk factor for having lung cancer. Old age is a great risk factor for having a stroke. Older people will be more likely to have a stroke than people who are young. People who smoke are more likely to get lung cancer than people who don't. The first thing to think about risk factors is, are they modifiable or not? Only some of the things that we consider to be risk factors are things we can actually do something about. I can stop smoking, but without some very, very extreme surgery, there's no chance of me biologically becoming a woman. So the risks that accrue to me for being a male, I can't do anything about. But the risks that are attributable to me as a smoker, I could do something about. The most common risk factors that we come across that we can't do anything about are age, gender, and ethnicity, although there are a range of others. The next thing to think about a risk factor is, how big is it really? There are many things that we've found through studies to be risk factors, but only some of them are really, really significant risks, and others might be much less significant. So, it's useful to know that someone's at risk, but it's even more useful to know how big the risk is to them. For example, if I was looking at the risk of having a heart attack, as a smoker, I roughly double my chance of having a heart attack. So my risk is 2 times higher, or 100% increase. If I've got a very strong family of cardiovascular disease, my risk of having a heart attack is about 1.8 times higher. So it's an 80% increase on my baseline risk. If I eat a diet that's very high in fatty food, my risk of having a heart attack is 1.3 times higher, or a 30% increase. Why is it useful to know these things? Well, obviously, if I was a smoker with a strong family history of cardiovascular disease and I ate a diet high in fatty food, the thing that would make the most sense for me to do first would be to stop smoking, because it carries the highest risk of all of these things. My family history I can't modify, so there's very little I can do about that, and then my fatty diet I can address after I've stopped smoking. The other thing to recognize is that a lot of risk factors are proportionate to how much we partake of that risk. So for example, my risk of having a heart attack goes up quite a lot more if I smoke 40 a day than if I smoke 10 a day. If I eat meat 3 times a day instead of once a day, my risk of having a heart attack goes up. And if my BMI is 50 instead of 35, my risk goes up dramatically, even though both of those would be considered obese. So sometimes when we look at risk factors, we need to think about to what extent is the patient partaking of that risk. And this comes to the crux of it. As doctors, how do we use risk? The important thing to recognize is that we can use risk for individuals, and we can also use risk at population levels. But for individuals, the important thing to think about is we estimate risk in our patients almost every day. As somebody walks through the door, we're making a bunch of assessments, looking at them. We're thinking about how old they are, we're thinking about their gender, we're thinking about what part of town they've come from, we're thinking about what job they do, and all of those different factors will go into our subconscious analysis of the person's risk of having a certain condition. An example of this would be if two people walked into your office who were complaining of coughing up blood, and one of them was an elderly smoker and the other one was somebody from sub-Saharan Africa. The person who's an elderly smoker, you'd be much more likely to investigate for lung cancer, whereas the person who's come from sub-Saharan Africa, you'd be much more likely to investigate for tuberculosis. We can formalize risk by using scores, and we often do this. For example, the Q-risk calculator that GPs often use to estimate a person's chances of having a cardiovascular problem over the next 10 years is a very useful tool. And this tool allows you to estimate somebody's risk and then decide based on that risk whether or not you're going to, for example, put them on treatment with a statin, or do something like advise them to go and do a bit more exercise or stop smoking, etc. We can often use it when we know somebody's got a condition. For example, in people with pneumonia, there's a risk score called the CURB-65 score, and the CURB-65 you can apply to a patient, and it takes into account factors such as their age, what their blood tests look like, etc., and then gives a risk score of which gives you a calculated risk of them dying as a result of this pneumonia, and that helps us to decide whether or not we're going to admit them to hospital or not, whether or not we're going to give them IV antibiotics or give them something oral, and generally how quickly we'll want to follow them up. As another example of using people's risk factors, we can develop tools for GPs to look at a whole database of their patients, which would help them to identify the people who are most likely to get admitted to hospital in the next 6 months, and that will help them to then invite those patients into the surgery for a review. You can check that their medicines are optimal, you can check that their social supports are optimal and that people are looking after them as much as they can, and that everything's going well for them. Those are just some examples of how doctors use risk. If you're interested in learning more about risk, the talks by Professor David Spiegelhalter from Cambridge are always very, very interesting. I've got a couple of links there. One is to a website that he runs, and the other is to a quick YouTube talk by him. If you want to learn about the concepts of absolute versus relative risk, go to that website, tagged there. If you want to have a go at calculating your own cardiovascular risk, go to the Q-risk website and put in your figures and find out how likely you are to have a heart attack. And finally, if you wanted to find out more about the CURB-65 score for pneumonia, here's the website for the wiki. Thanks very much. I hope you enjoyed the talk. Cheers.